All right, thank you. I'm just going to go ahead. And the way I'm going to talk about this is by comparing Nigeria, where I work and where we've had significant challenges, to Botswana that has recently been posting some really big achievements, and looking at the two countries and trying to tease out and assess what is going on and how each country is has been having its challenges and how the other country has been having its successes, notwithstanding the fact that Nigeria has had successes and Botswana has had challenges as well. So just in looking in the background, I'm just kind of going to basics here, thinking about what makes things challenging in some countries. And you look at Nigeria, which is in West and Central Africa, at a population of over 200 million people. And versus Botswana, which is in East and Southern Africa, with a population of 2.6 million people. The HIV prevalence in Nigeria in 15 to 49, which is the, what we also call childbearing age, if we're thinking about PMTCT, is about 1.4%. But for Botswana, it's more than 10 times that, is 16.4%. Land mass in Nigeria is about 1.5 times that of Botswana. GDP per capita in Nigeria is about $2,100. For Botswana, it's about 3 times what it is for Nigeria, about $7,000. The annual number of pregnant women living with HIV needing PMTCT is about 200,000. That number is so hard to find. That's part of the challenges we have in Nigeria and with this particular number. And then for Botswana, that was a bit easier to find. It's about 800,000. So look at the population in Botswana and look at the population in Nigeria, and then look at how many pregnant women living with HIV are these estimated we are talking about. It seems counterintuitive, but that is what is going on. Now, going back and looking regionally, because especially for Nigeria, and actually for Botswana too, some of these issues are not country-specific necessarily, but more regional-specific, and I want us to look at that in that context as well. In West and Central Africa, you have about 5 million adults and children estimated to be living with HIV in 2022, but for ESA, we have about 4 times that. It's about 20.8 million people, and so keep that in mind as we also talk about the estimated number of children newly infected with HIV. In West and Central Africa, is about 51,000 in 2022, but then for East and Southern Africa is 58,000, and this is where we shouldn't be, we as in WCA, shouldn't be competing with ESA in the number of children newly infected with HIV, but you can see that even though we have less prevalence and fewer people, the sheer number of children we are going to have to deal with who are newly infected with HIV is much, much disproportionately high. So what are some of Nigeria's challenges? And I want to put that in the context of West and Central Africa. Now, Nigeria is one of 4 West and Central African countries among the 12 countries in phase 1 of the Global Alliance to End AIDS in Children by 2030. And this was launched in July 22 at the last year's International AIDS Society meeting in Montreal. And the other WCA countries are Cote d'Ivoire, Cameroon, and DRC. So those are countries that, including the 12, are of most concern with respect to ending AIDS in children. Now, WCA, or West Central Africa, has these characteristics. We have low prevalence of HIV, but a high number needed to treat. And with that high number needed to treat is, if you think about it in terms of statistics, it's a high cost per number of people we need to find. We have to spend more money, more tests, more time, and in cases of countries like Nigeria, cover more land mass to find one person living with HIV. And children are much more difficult to find than adults. We have less robust health systems and social support programs. You see in East and Southern Africa, they are the health systems are a bit better. You are able to get people to come back. You have lower loss to follow up, and we have more resources to find people and bring them in. Social grants, et cetera, are available to support people. Our data and monitoring systems and research outputs have issues. And for some of the data I was looking for, for this presentation, the data was available for Botswana, but not for Nigeria, and it's really, really frustrating. We have insecurity, not only in Nigeria, but in parts of West and Central Africa. It seems as if at any point in time, there's one conflict or the other, there's one issue or the other, not to talk of outbreaks and other diseases that are really disproportionately affecting the region. Then we have very problematic political will and governance. I would say for all of Africa, there's problematic political will and governance, but we sometimes have really significant issues in the region of West and Central Africa, which is impeding our success in this area. So we really are looking for needles in a very complicated haystack when it comes to Nigeria and West and Central Africa, or as my grandmother would say, looking for stones in a big bowl of beans. It's very, very difficult to find. It takes a lot of effort to find, and sometimes you end up cooking the beans and find the stones at the time when you're supposed to be eating the meal. And with the Global Alliance, the four pillars that we are trying to look at are early testing, and optimize comprehensive high-quality treatment and care for infants, children, and adolescents. And the theme of this talk being really squarely in pillar 1 there. Then 2, we want to close the treatment gap for pregnant and breastfeeding women. Then with HIV and optimizing continuity of treatment, meaning once we engage them, we need to keep them in the program. And then 3, preventing and detecting new HIV infections among pregnant, breastfeeding adolescents and women, and then addressing rights, gender equality, and the social and structural barriers that hinder access to services. And you will see when I start talking about Botswana, they had some of their achievements certified in 2021, and this Global Alliance was established in 2022. You will see a pattern of what Botswana did that really is filling the requirements for pillars 1, 2, 3, and 4, even before we made that a requirement in the Global Alliance. And I would say that a lot of that probably was also drawn from successes from in Botswana and other countries that are doing much better. So there are stark differences in PMTCT performance between Nigeria and Botswana. You can see on the left there in what is labeled figure 3, and this is from Start Free, Stay Free report from 2021. You can see that Nigeria has about 15% 6-week transmission rate, and then breastfeeding transmission rate of 10% for a combined transmission rate of 25%. We should not be seeing these numbers in 2022 or any of the 2000s really from 20. Then this data is from 2020. And then you can see down on that same figure 3, Botswana with the orange box covering it there, is that they had 1% 6-week transmission rate, 1% breastfeeding transmission rate for a grand total of 2%. Very, very different. And now if you go and look at the figure 13 on the right, where we are looking at percentage of HIV-exposed infants that were tested by 2 months of age, you can see that Botswana, they flipped positions, where Botswana is, one of the leading countries here with coverage of HIV-exposed infants with early infant diagnosis by 2 months of age. And then Nigeria now falling to the bottom of the chart, where we are having barely 20%, not even 20% in, a little over 20% in 2020, and not moving that far from close to 20% in 2015. So we are not making really good progress at the rate at which we should be making in Nigeria. Now, Botswana's successes in implementing early infant HIV screening, we can think of it in the context of East and Southern Africa. Elaine has already mentioned some of the data in East and Southern Africa. High prevalence, but relatively lower populations, lower number of people in the population. And so you have Botswana in 2021, of December 2021, becoming the first high HIV burden country to be certified by the WHO for achieving a critical milestone in eliminating vertical transmission. And what was that? They were certified for achieving silver tier criteria. And that means an HIV case rate of fewer than 500 per 100,000 live births, vertical HIV transmission rate of under 5%. I showed you the 1% early, the 1% late, for a total of 2%. And then antenatal care and ART that has been provided for greater than 90% of pregnant women, meaning that their coverage for ANC and for ART was greater than 95%. Now, and then also 95% of pregnant women in Botswana were receiving ART in greater than 95% were receiving ART in 2021, up from 77% in 2010. So you can see that really they had made steady strides in getting that down. And as I also mentioned from another slide, the total vertical transmission rates were 2.2%, down from 9% about 10 years before that. So just to show you in what they achieved was, it's on this slide here. In the middle is what Botswana achieved. So they surpassed bronze, they had silver, and I'm sure right now they are going for gold and will probably reach there in the next couple of years or so. And then there's full validation, which, you know, every country wishes that we could reach there, and then a lot of us here would be out of work or retired or look at something else, which would be absolutely wonderful, because I want to retire on an island and drink, you know, mojitos until I die. Unfortunately, I can't do that right now because I decided to be born in West and Central Africa. So in terms of Botswana, and looking at the trend over the last 20 years or so, you can see really how they have moved. Look at the blue line for proportion of women tested for HIV, the purple line for program uptake, and then the red line below for percentage of babies who are HIV infected. And you can see how they've gone up in the right direction for the right indicators, and then have come down in the right direction for the right indicators, meaning HIV-infected babies. So this is one slide that is showing the story. And as Elaine said, there's a lot of good data that CDC puts out about some of their success stories, and then this is where I got this information. So it's a really nice snapshot to see the direction in which Botswana has been going the past 20 or so years. So how did they actually achieve this? And I've been to different presentations where we've had people from Botswana presenting. I tell you, I've been sitting there, and this is how I was looking at them. Just really happy for them, but also very jealous of what they're achieving. So women living with HIV were placed at the center of the country's EMTCT implementation and documentation efforts process, at the center. I'm not going to stand here and talk about point of care, EID, or you know, HIV DNA PCR being done at birth or before final outcome and all that. We all know those tools in the toolkit. We've been talking about them ad nauseum. But there are some things that we may think are not important, or we underestimate their importance, and that's what I'm going to stress on here. The networks of women living with HIV were oriented and supported to administer EMTCT-related and human rights assessment tools across Botswana's districts. And these are some of the things you see in the 4 pillars that the Global Alliance is proposing that we do to really end pediatric AIDS by 2030. So these networks led the process, and the government of Botswana provided logistical support to ensure the engagement of women living with HIV within a safe space. Very important. The women living with HIV were also represented on the National Validation Committee and reviewed a draft of the National Validation Report. So in talking about that, what are some of the lessons learned for Nigeria and other countries that are looking to replicate Botswana's success? First of all, we need to be aware of our context, whether national context or regional context, and optimize our monitoring and evaluation processes and the robustness of the data that is relevant to the goals that we want to achieve. And you know, and it's almost poetic that when I was looking for data to present in this presentation, there were several places where Nigeria data was blank, and I just was like, I'm not trying to see this right now, but that is what is going on in some of our, for some of our indicators. We need to use an implementation science. I'll always talk about implementation science. We need to use an implementation science, rights-based, women-centered approach. It embraces structured and intentional community engagement, not carrying them along, not outreach, not having 1 or 2 meetings, engagement, leadership, involvement, participation to the fullest extent. And then doing this with durable partner support. We cannot do this alone, but particularly when we are countries that have significant issues with finding funding, that's internal domestic funding. We need to do this with partner support, but it's not only for financial support, but other types of support, technical support, moral support, all of that. And noting that Botswana had partner support, including PEPFAR, UNAIDS, the International Community of Women Living with HIV, but then also local HIV and women's groups. And then EMTCT efforts and approaches should be data informed at baseline, data-driven during implementation, and the results should clearly be reflected in data. We just can't come up and be saying, we did this and we did that, but you don't have data to reflect that result. And Botswana was very clear in their presentations about how they started intentionally documenting every little thing they did, not only outcome indicators, but process indicators. So I will end there, and thank you all for your attention.